All right, Dr. Rand, we're back for Ask the Doc. It's been a minute.
Yeah, I know, right?
I miss you, man.
Well, it's been summer, right? I miss you too always, but I guess we've both been playing hard, right?
I know. That's the way it is.
Summertime.
Yeah. Hey, I want to talk about something cool because I tell you all the time, people are reaching out to me and asking me, "Man, Dr. Rand's so cool. I wish you could be my doctor and stuff." And of course you do. You're based out of Santa Monica, but you also do a Skype interview and all that stuff. But you have a new project that just recently opened in Texas. Talk to me a little bit about it.
Well, yeah, we do telemedicine. So I'm licensed in something like, I want to say 38 states. And that makes it a lot easier too. But we've been able to do telemedicine for quite a while, not just with COVID. Okay, I engaged Greenberg Traurig, a pretty great law firm way back in the day, and Yvonne Grossi was involved. She was the head of the medical department, and we figured out all the ways to do it properly. So we've been doing it for a while, and it makes life easier for someone who lives in, just pick place, Alabama.
Yeah.
And I say a place like that because in the big cities, you tend to have some of the newer stuff. Los Angeles. People know about TRT for a long time. As a matter of fact, Houston, which is where we've opened up a new office, I think is even bigger than Los Angeles.
Really?
In those places, it makes more sense, I guess, to have a local shop.
Yeah.
But yeah, we've been doing this for a while, and we do have a new shop in Houston, which enables us to do things that you can't do with telemedicine. We can't do pellets, for example, via telephone. So, we're excited about that. We're in the Woodlands, and Dr. Todd's out there, Dr. Todd Kleiman.
How can people find out the address and all the info for that?
It's on the website.
Okay.
On our website,
PSR. Yep.
PSRmed.com, Papa Sierra, Romeo, MED.com, and it'll give our new address. But, a lot of people, to that end, they want to go see a doc.
Yes.
We were talking about this at lunch. Telemed just doesn't cut it.
Yeah.
I would argue there's certain situations where that makes nothing but total sense. I mean, if I'm going to get a shoulder replacement, someone's got to examine me. But in something like this where you're really just using internal medicine and arguably endocrinology, obviously too, do you really need to have somebody look at your shoulder? So anyway, we can manage to do it with telemedicine, and we can always use we call a surrogate physical exam, so that we depend on another physician to say, hey, yeah, this fella or the gal's in great shape. Here's what you need to look out for. Or here's a past medical history that concurs with the history we take, et cetera, et cetera. So there's ways to do it telephonically is the point. And whether it's, telephonically or with Skype, or now the big deal is Zoom, right?
Yeah.
And it helps a lot more people that way. But yeah, Houston, we got Dr. Todd there.
Awesome.
He comes from to us, I should say, from Baylor University. Used to work with one of my favorite docs, Dr. Lipschultz. Yeah,
we've talked about it many times.
Yeah. So we're up and running there. So
awesome.
People in that area, come on in.
Well, congrats. I hope that many more will pop in throughout the country for you.
Yeah, me too.
Awesome.
So. Yeah, thanks. So I'm reading the questions. First one, right?
Yeah.
And do I gather correctly, these were grabbed off of the YouTube site?
Yeah, so these were actually from the comments of YouTube, yeah. So people have been posting more in the YouTube comments.
Well, this one, and I noticed this because they're all structured the same way. This is from Michael Atkinson, and he says, I seem to be in the rare group of people who experience heightened anxiety on TRT. It started almost immediately after the injections started a year ago. Starting dose was 200 milligrams divided into 2 shots per week. Anxiety was very high. Cut the dose to 100 milligrams a week divided by 2 shots. Anxiety got a lot better, but was still there. I just had it lowered to 40 milligrams per week divided by 2 shots. I'll see how it goes, but if it doesn't work, what is my best option? Go to HCG? I'm feeling kind of desperate, thanks. So, again, I can't practice medicine here because it's just not appropriate. I need to have a lot more information, the things we talked about just a minute ago, like a full history and physical. But
have you ever had someone tell you that they got anxious as they did TRT?
Yeah, I mean, one of the risks with testosterone is that, and I use this word a lot, it leverages a lot about an individual. We talked about someone being a jerk and giving them more energy to be a jerk. It doesn't make them one.
Right.
whereas excess estrogen can turn someone from Dr. Jekyll into Mr. Hyde, right? In this case, if you've already got generalized anxiety disorder or something like that, right? If you haven't been diagnosed, look into it.
Accentuate.
Then if you get more testosterone in your system, you'll have more energy to be what you are. And so it can heighten anxiety. Now, there's a flip side to that. And it makes sense because if you look at some of the medications used for generalized anxiety, some of the more successful ones include what we call a norepinephrine uptake inhibitor. And norepinephrine is another word for adrenaline. So you're thinking, wait a minute, someone's got an anxiety disorder and I'm going to make it so we raise their levels of adrenaline? That sounds crazy, right? Well, we're not always sure in psychiatric medicine, and I'm not a psychiatrist, but I did enjoy 3 different rounds with one of the most brilliant guys I ever met, Dr. Nathan Dixon, when I was going through school, a psychopharmacologist. He was an engineer first, because it was so intriguing. We don't have all the mechanisms down, and there's a lot of trial and error in psychiatric medicine. But again, on the surface, you go, that doesn't make any sense. You're going to make someone with anxiety even more anxious. Adrenaline is the worst thing to give to somebody. Or in this case, noradrenaline, which is more short acting, I should say. Anyway, we won't get into all that. But, because the balance is so important, right? I use the example with testosterone. You can feel more anxious if it's low, actually, right? And you're not normally an anxious person, just because a lot of times, whether you're a control freak or not, just not feeling yourself makes you feel anxious. You're like, okay, what's going on here? So if we can get someone who might be in that state, just to use this as an example, a little more energy, pep them up a little bit. Norepinephrine can be great. Maybe not in excess, though, right? I mean, norepinephrine is one of the things that's released when you go into cryotherapy. You know? So at least it's one of the things that's given credit for feeling so good afterwards. So if we get the right amount, in other words, on board, it can actually work to help people with generalized anxiety disorder. But back to this question, testosterone can again leverage someone who's already feeling that way just by giving them more energy to feel that way. What I'm seeing here, though, is typically this would be very rare at this point, to assume that, say, after he cut it down to 100 milligrams a week, he's really getting anything out of it. I think I've stated before, in my clinical practice, it's rare that I see anyone get benefit from less than 200 milligrams of testosterone cypionate a week. Doesn't mean it can't happen, but then you drop down to, say, 150, and then you go, okay, you really drop below the therapeutic minimum threshold that's required, and one we've known about since the 1950s, to alleviate the signs and symptoms of testosterone deficiency. So there's probably something underlying going on here. And again, I'll say it, go visit a doctor personally or telephonically, but I mean, get someone to look into your history completely. But the other thing that's not addressed here is estrogen. Conversion from testosterone that you're introducing into more estrogen or even excess estrogen, right? Wouldn't be as much of an issue, presumably, with a really small dose of, what amounts to 40 milligrams a week. But it could be at the higher dose. And again, everybody's different, not just with the reaction to estrogen by itself, but that ratio of not just, estrogen to testosterone, but all the other androgens and progesterone, DHA, et cetera. So, I would look into doing this the right way. And I say that because I don't know if it's the wrong way or right way, but we haven't mentioned all the various things that are required to do TRT right anyway. As far as HCG goes, Michael Atkinson did not give an age, right? Or I don't have it listed here. HCG is not going to do much for a male who has certainly reached the age of 35 by definition. In my experience, largely because of stress in the 21st century, the efficacy of ACT drops. Maybe you can get away with it at age 28, 29, maybe even 30. But I think we've talked about this before too. Even if you do get some benefit, it doesn't last very long, either because time runs out or because you're on it for so long at around that age. And I can't explain why it tends to fade. But I think I've said this before. It'll work for someone at, say, age 29 for 6 months to a year. and the levels won't change. They might be at 1100 total T, nanograms per deciliter, and a free T commensurate with that. And the patient comes in and says, "Yeah, I know. I'm looking at the numbers myself, but I can't explain it. But I just don't. I feel like I did when I first came.
Yeah.
The wheels fell off the wagon." So HCG may or may not be an alternative if this person is young enough. Also, the other little thing that comes with HCG that rarely makes a difference, but it's worth mentioning here just because I can't really do much to help the desperation he remarks about. HCG can encourage your testicles to also make some estrogen, which if you've got an estrogen deficiency could obviously make up for it. If you are in a position where you are low in estrogen, whether it's absolutely or in relationship to testosterone, and you're not using an aromatase inhibitor or something to block the estrogen receptor like a SERM, and you're still not producing enough estrogen. I don't know if that makes sense, but anyway, HCG may or may not be useful, but I would suggest, Michael, that you find an expert that can help you get into the weeds in this and really figure it out. Anxiety, and this is something I started to go off on a tangent about, sorry, with the norepinephrine reuptake inhibitors, you wouldn't think it would be useful for someone with anxiety. It would only exacerbate it. But here's the thing with testosterone. While I say that if you've got generalized anxiety disorder and you would consider testosterone leveraging whatever you got, one of the things that counters that is testosterone's a very effective antidepressant. Okay, it's a feel-good hormone, so that if you're on testosterone and you start to feel better, well, then you could argue you're leveraging feeling better, and you just have more energy, which doesn't necessarily go to anxiety, but goes to just being your, otherwise usual or better self without the anxiety. Does that make sense?
Yeah.
So, sometimes that might involve finding just the right dose, yes, but also the right balance between some of the other androgens and, of course, estrogen always. So just things to consider here whenever Michael goes and does this, what I would consider the right way with a doctor. Okay?
All right. Thanks, Doc.